Assalamu alaikum. I'm sorry we are late a bit. I think it was some administrative issue with that. So, welcome to all. Who is the first presenter is Rida Wasi, and her topic is to assess the rationality and outcomes of antimicrobial prophylaxis in colorectal cancer surgery, a retrospective cross-sectional study. Do we have Rida Wasi? All right, thank you. Can you please put on the presentation for Ms. Rida Warsi, Dr. Rida Warsi?
I raised my hand.
नीचे देके पढ़ना तो क्या
When the timer starts, okay. Assalamu alaikum everyone. This is me, Rida Wasi, ASHP resident pharmacist, and I'm going to present my research study in front of you all that I conducted during my residency program. The topic of my residency research topic was to assess the rationality and outcomes of antimicrobial prophylaxis in colorectal cancer surgery. It was a retrospective cross-sectional study. Why is it not visible? Okay, colorectal cancer. Colorectal cancer is the third most common cancer globally, and it is the second most common cause of cancer-related deaths worldwide. In Pakistan, the prevalence of colorectal cancer is also very high. If the prophylactic antibiotic is not given, the rate of surgical site infection related to colorectal cancer surgery would also be very high. So, there are two ways for treating colorectal cancer with surgeries: open and laparoscopic procedures. The surgical site infections are said to be more related to the open procedures than the laparoscopic procedures. It is said, what is surgical site infection? Surgical site infections are the one that occur within 30 days after a surgery. What were the aims and objectives of this study? The aim of this study was to assess, determine the difference in rate of SSI in the patients receiving standard antibiotic prophylaxis, and if they were compared to the extended duration antibiotic group. Now, what is standard antibiotic prophylaxis group? They are the patients who received the antibiotics as recommended by the guidelines. And the extended duration antibiotic group was the one who received the standard antibiotic prophylaxis recommended by the guidelines. And in addition, they received an extended duration of antibiotics too. The objectives of this study were to determine the rationality of prophylactic antibiotic used in the colorectal cancer surgery and compare it with the standard guidelines. The incidence of SSI in open versus laparoscopic procedures, and to determine the length of stay in patients who received extended duration of antibiotics. Coming towards the methodology, after receiving the IRB approval, I conducted my study in Shaukat Khanum Memorial Cancer Hospital, and the data was collected retrospectively of the year 2022. The data was retrieved from HIS and the sample size calculated was 98. Why is this slide not visible? Okay, the inclusion and exclusion criteria, let me tell it on my own. The inclusion criteria was such that all the patients who were adult and having an elective colorectal cancer surgery were included, and the patients that were excluded from the study were those who had cancer perforation, unresectable disease, or the patients who were receiving antibiotic preoperatively. The data was analyzed using SPSS version 16. Chi-square test was applied for qualitative variables and sample t-test was applied for quantitative variables. Patient confidentiality was not breached during the study. Moving towards the results. Now, this is the table that represents my study. As we discussed before, we were having two groups, the standard group and the extended duration group. The standard antibiotic prophylaxis group was the one who received the antibiotics that were recommended by the guidelines, and extended was the one who received standard antibiotic prophylaxis along with an extended duration of antibiotics. In the first group, we had 75 patients, and the other group, we had 25 patients. When we talk about gender, so we had 74 males and 26 females in the study. Talking about the age, the mean age of both the groups were 44.39. And now this is an important thing, talking about the operating technique. We had 7 patients who underwent open procedure and 93 patients underwent laparoscopic procedures. Among those open, 2 were the ones who received standard antibiotic prophylaxis and 5 were the ones who received extended duration prophylaxis. Antibiotic. And the laparoscopic ones, 73 were standard and 20 were extended duration antibiotic patients. As we can see, the hospital stay was significantly increased with an extended duration of antibiotics. Also, the surgical site infection. In our study, we had 7 patients who got surgical site infection. Among them, 4 received extended duration antibiotic and 3 received standard antibiotics. The readmission due to infection was 2, and that was also in the extended duration antibiotic group. This is an important slide representing the procedure of the surgery. 93 patients underwent laparoscopic procedures, and among them, 3 developed SSI. And among 4 patients who underwent open incisional procedure, 4 of them developed SSI. That was a huge number. Hospital stay, the average length of hospital stay was from 0 to 5 days. This is a slide representing the culture reports of the patient who had SSI. The common antibiotic given to the patients in extended group was peptaz, along with other antibiotics, as we can see, Cipro, cloamoxiclave, and other cefixime 2. Moving towards the discussion. As we saw, we had 7 patients that makes 7% of our data who developed SSI in our study. When we see the literature, it is comparable to the literature, that is 15% and 4 to 9%. Also, there was no statistically significant difference of SSI between the standard versus extended duration of antibiotic, and only it was inappropriately increased in 25% of patients. When we see the literature also advocates discontinuation of antibiotics postoperatively, and it also suggests that antibiotics should be discontinued after the procedure. The SSI incidence was significantly associated with the operating technique, as we saw that in open procedure, we had more SSI. An extended duration of antibiotics significantly prolongs the length of hospital stay in the patients. Moving towards the study limitations, as I had only 1 year of my residency program duration, so the study duration was also one of the factors, and I could not see the antimicrobial resistance among the patients who developed SSI. What is the future perspective of this study? I would like that a more dedicated time to look for antimicrobial resistance would give more strong foundation to this study. Also, such kind of research should be extended in the public and private sectors of KPK for more exposure and for more looking for the antimicrobial resistance. In conclusion, the last slide, it says that open colorectal surgery is associated with an increased risk of surgical site infections as compared to the laparoscopic procedures. Also, administration of antibiotics longer than 24 hours have no significant effect on preventing the SSI, and extended duration of antibiotic could not reduce the hospital stay or readmission. These are the references of my study. Thank you. Thank you so much.
Thanks, Dr. Rida. I'm joined by Dr. Hajra Riyas, who's consultant nuclear medicine. Can I just reiterate that please take 8 minutes for the talk and then leave 2 minutes at the end for questions. You're just running out of time, but one question. If you have to conduct this study as a prospective study, how would you do that?
Sir, I will definitely look the data in the as it's happening, and I will collect the data in time, and will look and would follow the patient for 30 days, that whether the patient develops as an SSI or not. So that would be my approach to that. And till I have sufficient data, I will keep on collecting conducting my study.
Right. Any questions? Okay, thank you.
Thank you so much. Thank you, everyone.
So the next talk is Pioneering the Fast Forward Trial Impact, Retrospective Analysis of Acute and Long-Term Toxicity, to be presented by Dr. Yasir Inam. So the time is 14:15. So if you just stick to 8 minutes and then leave 2 minutes for the questions. This is
Good afternoon, everyone. I'm Dr. Yasir Inam from the Department of Clinical and Radiation Oncology, Shaukat Khanum, Peshawar. And I'm going to present a retrospective analysis of acute and long-term side effects in breast cancer patient treated with ultra-hypofractionated radiation therapy, which is the fast-forward protocol at a specialized cancer center. So this was our team who conducted this retrospective review. I have no disclosures. uh, breast cancer is the most common cancer among the female. Uh, 1 out of 9 female develop breast cancer at some stage in their life. Uh, every year, 83,000 new cases are reported annually in Pakistan, and 43,000 female die of breast cancer everywhere in Pakistan. So the standard care for breast cancer includes surgery, chemotherapy, radiation therapy, and hormonal therapy. Some of the patient will have all these four modalities, and some of them will have surgery and radiation therapy and hormonal therapy only, depending upon the stage, size, nodal involvement, and hormonal receptor status. As far as radiation is concerned, so the standard radiation therapy regime for breast cancer is 40 gray and 15 friction, which is a 3-week treatment regime. Our study mainly focus on a 5-day frictionation therapy, which offers shorter treatment duration, improved patient convenience, and reduce hospital resource burden. So this is a single center retrospective review conducted at Shaukat Khanum Memorial Cancer Hospital, Peshawar. The inclusion criteria was early stage node negative breast cancer patient, mainly T1 to T3. This study was conducted from January 2021 to December 2022. After radiation therapy for acute toxicities, first follow-up was done at the end of the treatment. Second follow-up was done 4 weeks after the treatment. Third follow-up was done at 8-week post-treatment, and fourth follow-up was done at 12-week post-treatment. And for long-term toxicities, subsequent follow-up were done at 6th and 12 months to assess the late toxicities. Data was analyzed and used SPSS version 26, and for acute and late toxicities, common terminology criteria for adverse events version 5 was used. All radiation treatment were delivered using field and field forward IMRT technique, and all the patients were treated in supine position, immobilized by the breastboard. So here you can see this is a left side breast cancer patient planned for radiotherapy. The pink line here, if I can show you, the pink line shows the clinical target volume, and the red line from the outside showed planning target volume. And the color wash here is the area which will actually receive radiation therapy. So here you can see that this patient is perfectly planned, and there is no dose outside the target volume. So before delivering radiation therapy, there are some parameters which need to be achieved. And the most important of them is the 95% dose to the target volume. So in this case, 95% of the PTV, which is the planning target volume, should receive more than 90% of the prescribed dose. And while treating breast cancer patient, there are 2 main organs which are at risk of developing toxicity. One of them is the ipsilateral lung, and other is heart. So we need to deliver safe and effective radiation therapy. We need to achieve the dose constraint for the lung and heart. So in this case, the ipsilateral lung should not, 30% of the ipsilateral lung should not receive more than 75% of the prescribed dose. And as far as heart is concerned, so 25% volume of the heart should not receive more than 5% of the prescribed dose. And another parameter is 5% of the heart volume should not receive more than 25% of the dose. And our study, all of these parameters were achieved. So now coming to the results, it was a retrospective review, as I mentioned earlier, 86 patients who received 26 gray and 5 friction, and some of them received a boost to the tumor cavity, including 5 friction, so make it total 10 friction. The median age was 51 years, and right side was the most common tumor site, which make it 54.7%, and left side were 45.3%. The most common histological type was ductal invasive carcinoma, and all patients were treated using field and field forward IMRT technique. So now coming to the toxicities, though, radiation dermatitis is the first toxicity, and majority of the patient, 59.3% patient in our study didn't develop any radiation dermatitis. 38% of the patient developed grade 1 dermatitis, and 1.2% developed grade 1 dermatitis, and only 2.3% experienced grade 2 radiation dermatitis at the end of the follow-up. Only 2.3% developed grade 1 lymphedema at the first follow-up, indicating a low incidence. And 1.2% developed grade 1 skin hyperpigmentation, and 97.9% didn't develop any skin hyperpigmentation. Now coming to the long-term toxicities, so 27 patients were excluded from chronic toxicity assessment due to incomplete follow-up, and the late toxicity was also low to minimal. Only 3% patients were having tolerable lymphedema, and 14% experienced mild breast shrinkage. 95.3% of the patient didn't develop any radiation-induced pneumonitis. Only 3.5% experienced grade 1 pneumonitis at the third follow-up. 1.2% had grade 1 pneumonitis at the fourth follow-up. So comparing our data with the original trial, which is the fast-forward trial, our results are very much comparable with that of the original trial. So in our study, only 38% patient developed grade 1 skin reaction, while in the original trial, 63.5% developed grade 1 skin toxicity. In our study, 2% patient developed grade 2 skin toxicity, while in the original trial, 15.9% patient developed grade 2 skin toxicities. So in our study, 2.3% developed grade 1 lymphedema, while in the original trial, 2.4% experienced mild or moderate grade 1 lymphedema. So in the original study, they didn't look for radiation pneumonitis, but in our study, only 4.7% experienced radiation-induced pneumonitis at 8 and 12-week follow-up. So in conclusion, adjuvant breast radiotherapy using a 5-fraction hypofractionated treatment is a safe treatment option in patients with node-negative early-stage breast cancer and has a low incidence of acute and long-term side effects. It has significant potential to reduce the demand on busy radiotherapy centers by reducing the number of required fraction for the required treatment. Thank you so much. Any questions?
Riyasir. So one question from me. The original trial, the risk of radiation dermatitis was significantly higher than your study. So why do you think that is?
I think mainly the reason is the difference in population. Those trials were conducted mainly in Western countries where the patient have fair skin and they are susceptible to radiation-induced dermatitis more as compared to our population. So I think the population difference is the main thing.
So do you think brown skin is a protective factor?
I think so. I don't have any evidence for this, but yes, I think that's the main reason.
Well, I think I would disagree because brown skin burns as well.
Yes.
Any question?
Thank you.
Thank you
so much.
Thanks. Speaker is Dr. Asadullah, and he's going to present assessing the duct to parenchyma ratio as a predictor of post-operative pancreatic fistula. So Dr. Asadullah from SKMC Peshawar.
Assalamu alaikum. I thank you all for joining us here today. I am Dr. Asadullah Khan, fellow in hepatopancreatic biliary in Shaukat Khanum, Peshawar. So today I'll be sharing with you my study regarding a very critical aspect in the post-operative management of pancreatiduodenectomy, commonly known as the Whipple's procedure. The title of my study is Assessing the Duct to Parenchyma Ratio as a Predictor of Post-Operative Pancreatic Fistula. So we can all agree on this, that Whipple's procedure is a very complex and demanding surgery, and the post-operative pancreatic fistula is a well-known and dreadful complication of that procedure. The incidence ranges from 13 to 41% in established centers. And in the Western population, the duct-to-parenchyma ratio has been readily proposed as a predictor of the postoperative pancreatic fistula. During our literature review, we did not find any study which investigate or validated this in the Pakistani population. So, according to the International Study Group of Pancreatic Fistula, in 2016 revised definition, postoperative pancreatic fistula is defined as any drain amylase level which is more than 3 times of the normal on post-op day 3 and beyond is called as postoperative pancreatic fistula. The mortality in established center is from 2 to 4%, and they have divided it into 3 types: type A, B, and C. A is not clinically relevant, while type B and C are clinically relevant, and it is the type B and C which particularly need attention and optimization in the post-op period for the patient, because these type B and C fistula leads to dreadful complications. So, why the need to predict postoperative pancreatic fistula? If the surgical team is able to predict that a particular patient is at risk of developing a postoperative pancreatic fistula, they will properly plan preoperative optimal nutritional optimization of the patient. They will address any modifiable risk factors like diabetes or hypertension. The surgical team will properly tailor their surgical approach in the form of anastomosis, and they will involve a senior hepatobiliary consultant, because it is the experience of the surgeon and not the surgical technique which determine the postoperative pancreatic fistula. So patient counseling is also very important, because the patient didn't know what will happen to me in postoperative phase. And if we can tell them that postoperatively he is at high risk of developing a fistula, so that will properly counsel the patient and will address the need of the patient. So these patients will postoperatively need close monitoring, and by close monitoring, if we can detect any signs and symptoms of postoperative pancreatic fistula, we will do timely intervention. So how to calculate it? It doesn't need any complex mathematical equations or formulas. We just need a cross-sectional CT image in which we will locate the transaction point, which is when the splenic vein joins the SMV. This is the transaction plane. We calculate the duct diameter, and then we calculate the parenchymal diameter, and we divide the duct diameter by parenchymal diameter. So it is simple. The objective is to assess the effectiveness of duct to parenchyma ratio as a predictor of postoperative pancreatic fistula in Pakistani population. It is a retrospective study undertaken from May 2021 to July 2023. IRB approval was taken. Data was collected from hospital information system. Data analysis was done using SPSS, and p-value of less than 0.05 was taken as significant. All the patients who were referred from MDT for pancreatoduodenectomy were included in the study, while those patients who had metastasis on the preoperative imaging, patient undergoing emergency surgery, patient undergoing distal pancreatectomy, and those patients in whom we could not measure the pancreatic duct in the preoperative imaging were excluded from the study. So in our study, the sample size was 63, 39 were male and 24 were female. The overall clinically relevant postoperative pancreatic fistula, which is type B and C, was 19%. Of the 19%, type B was demonstrated in 17.5% of patients, and 1% developed a type C fistula. So in patient in which we calculated duct to parenchyma ratio, which was less than 0.2, those patients 81.8% developed a type B fistula, while in those patients in which the duct to parenchyma ratio was more than 0.2, 18% of patients developed the type B fistula, which was clinically significant with a p-value of 0.01. Unfortunately for us, and fortunately for the patient, only one patient developed a type C fistula. It was not clinically significant. The overall morbidity was 44.4%, which is in alignment with the international studies, and there was no 30-day or 90-day in-hospital mortality. Regression analysis was carried out, which showed a significant correlation between the duct to parenchyma and the clinical relevant postoperative pancreatic fistula, and it showed negative correlation. That is, if the duct to parenchyma ratio decreases, the risk of developing postoperative pancreatic fistula increases. So from the study, we conclude there's those patients in which the duct to parenchyma ratio was less than 0.2. Those patients are at high risk of developing postoperative pancreatic fistula and should be observed closely in a postoperative period for developing any complications. The ductal-parenchyma ratio should be incorporated in the preoperative management of all the patients undergoing pancreatic duodenectomy. In the Shaukat Khanum, we have the luxury to order different investigation without any hold up, but in public sector, these are very difficult to carry out. So the advantages of ductal-parenchyma ratio is that it is purely preoperative, unlike other risk assessment formulas. It does not require any complex calculation, as I have already demonstrated. It is cost effective because triphasic CT is a prerequisite in all patients undergoing pancreatic duodenectomy. So we only need that CT. That doesn't need any further investigation, preoperatively or inoperatively. The limitation of the study was that due to a very small incidence of type C postoperative pancreatic fistula in our cohort, the ductal-parenchyma ratio was not significant for the type C postoperative pancreatic fistula. In a larger sample, we may be able to validate that. These are our references. Thank you. Any questions? So basically, what the studies have shown that it is the technique, it is not basically the anastomosis, but it is the surgical technique that the senior surgeon will have a way to deal with the pancreas and the duct. He will use proper sutures for it. He will use loops for it, while an inexperienced surgeon might not have these facilities and might not be able to properly do the anastomosis, etc. Is the loops and the threads and the number of cases that the experienced surgeon will have.
Any other questions from the audience? Okay. So I have one question. Are there any techniques to assess the risk of pancreatic fistula, pancreatic duct fistula in the literature? And if there are any
Yes,
other techniques,
yes,
then how does it compare with yours?
Okay, so so international studies have done the comparison, but in our cohort there is no data regarding that, and there is FRS fistula risk model, modified fistula risk models. Some from the Koreans, they have assessed the parenchyma softness, or if they are thick, they have based their study on that. So for us, I think the duct-to-parenchyma ratio is very feasible and it is convenient and cost effective.
Thank you. Thanks.
Thank you.
So I'm going to now invite Dr. Amna Munawwar from SKMC Lahore, and she's going to present her paper on clinical outcomes of young rectal cancer patients in Pakistan, an institutional-based study. Dr. Amna Munawwar.
So I'm Dr. Yasir, and I'm from the Department of Clinical and Radiation Oncology. I'm going to present on the behalf of Dr. Amna Munawwar.
So the time now is 14:33.
Sir, there is some issue with the presentation. Can you call next speaker, sir? I'll
Yeah.
present after this.
Yeah,
Thank
of
you.
course, yes. So the next one is challenges in radiological diagnosis of chronic granulomatous mastitis, to be presented by Dr. Muzammil Rashid Bhutta from Shifa International Hospital, Islamabad. So have you got Dr. Muzammil Rashid Bhutta?
Nice.
Okay. So we haven't got him, unfortunately. So the next one is benchmarking excellence, evaluating advanced breast carcinoma care in Pakistan's largest cancer hospital against NICE guidelines, to be presented by Muhammad Uwais Kamal. No? Okay. So the next one is, well, if there's no presenter, we can't mark it. So the next one is adjuvant chemotherapy versus surveillance in stage 2 colon cancer, a comparative analysis at Shaukat Khanum, to be presented by Dr. Riaz Ahmed from SKMC Peshawar.
Good afternoon. My name is Dr. Riaz Ahmed. I am working as a fellow colorectal surgery at Shaukat Khanum Hospital, Peshawar. I'm here to present the comparative analysis of chemotherapy versus surveillance in stage 2 colon cancer patients treated at Shaukat Khanum Hospital. I have no conflict of interest to declare. So first of all, a brief epidemiology. So worldwide colon cancer is the second deadly and fourth most commonly diagnosed cancer in the world. Nearly 2 million new cases and around 1 million deaths they were seen till 2020. The incidence has been increasing worldwide, especially in the developing countries that are adopting the Western way of life. Obesity, sedentary lifestyle, red meat consumption, tobacco, and alcohol. These are the main driving factors behind the growth of these tumors. However, due to recent advances in screening, early detection, and treatment options, the cancer-related mortality in developed nations, it has reduced even in the face of growing incidence. In Pakistan, colon cancer stands third following lung and breast cancer. Now, just like any other cancer, the earlier the diagnosis, the better the prognosis will be. Fortunately, colon cancer is a very relatively slow-growing tumor with the benign polyp typically taking around 10 to 15 years to develop into a cancer. Though the incidence has been increasing, but the potential for cure is known to increase when it is discovered early. The overall 5-year survival rate is 64%. If it is diagnosed at a localized stage, the 5-year survival is 91%, and we see around 37% of the patient in this group. If the cancer spread to surrounding tissues or organs, the 5-year survival drops to 72%, and we see around 36% of the patient in that group. In distant metastasis, the 5-year survival is 14%, and 22% of the patient can be seen in that group. Now, a slide about the treatment. Surgery is the only curative modality of localized resectable cancer. Currently, colon cancer patients, they are treated as upfront surgery, and the neoadjuvant systemic therapy is not yet the treatment. The current UK Foxtrot trial of introducing 6 weeks of preoperative chemotherapy is on long-term follow-up. Adjuvant chemotherapy is the standard for stage 3 disease, whereas it's used in stage 2 disease. It is recommended only if the patient is having high risk features for recurrence. And the choice of palliation is left if there is metastatic disease. Now, stage 2 cancer is basically the early stage of the disease without any involvement of lymph node or distant organs. In this group of patients, surgery alone is associated with high cure rate. And the role of post-operative chemotherapy is not yet the standard, or it's a matter of debate. But in patients with high risk features with recurrence, adjuvant chemotherapy is recommended even if there is a small survival benefit. So the main objective of our study is to compare the disease-free survival and overall survival in stage 2 colon cancer patients receiving adjuvant chemotherapy to those who just had surgery. We collected our data retrospectively through our hospital information system, which is basically a prospectively maintained database from which we undertook this study. All biopsy-proven stage 2 colonic cancer of either gender above 18 years of age with acceptable ECOG for elective surgery between January 2017 to December 2021, they were included in the study. The data was maintained on HIS and analysis was done on SPSS. A total of 246 patients with stage 2 colon cancers, they were included in the study, and there was a male predominance. Out of 246 patients, 106 patients, they received adjuvant chemotherapy because of the high-risk features, and 140 patients, they just had surgery and no adjuvant chemotherapy was given to them. We normally do MSI testing for our stage 2 colon cancer patients, but during the initial year, it was not a routine. So out of 106 patients who had adjuvant chemotherapy, 43% of the patients, in 43% of the patient, MSI was not done. Whereas MSI high was seen in 23% of the patient, and MSI stable was seen in 34% of the patient. Now, the reason that why adjuvant chemotherapy was given to the patient who were having MSI high or where MSI was not done, these patients, they were having high risk features for recurrence. So in 24 patients, T4 disease was seen. Poorly differentiated adenocarcinoma was seen in 21 patients. Fewer than 12 lymph nodes were seen in 12 patients. 7 patients presented with intestinal obstruction, and 3 each were having perineural and lymphovascular invasion. We followed the patient, and during the initial 2 years, a total of 18 recurrences they were seen. 10 recurrences were from that group who received adjuvant chemotherapy, and almost the same number, 8 recurrences were seen in that group who just had surgery. And in both the groups, recurrences were more common in that patient who had right hemicolectomy, either for ascending or cecal carcinoma. In mortality, we only included those patients who were operated in 2017 and 18 because then we followed the patient for 5 years. So the 5-year mortality in adjuvant group was 5.6%, whereas in non-adjuvant group, it was almost the same, more or less 3.5%. So this is the Kaplan-Meier graph for disease-free survival, and almost at 6 months, it was 78%, whereas it dropped to 30% at 16 months, and later on, it was 10% at the end of 2 years. And this is the overall 5-year survival graph. And at 20th month, it was 57%, whereas at the end of 5 years, it dropped to 10%. So in conclusion, ladies and gentlemen, stage 2 adjuvant chemotherapy still represents a dilemma in stage 2 colon cancers who were treated completely after surgery. But the finding of this study, it shows that if the patient is having stage 2 colon cancer and having high risk features for recurrence, they benefit from the adjuvant chemotherapy. If this was not the case, then the recurrences and the morbidity would be more in those patients who do not receive the adjuvant chemotherapy. Thank you.
Thanks very much, Dr. Riaz. I would welcome any questions from the audience, especially our medical oncology colleagues. So okay, there is.
No, we at Shaukat Khanum practice the standard technique, that is the central venous ligation, and we follow the normal anatomy. So our technique is standardized, and it is performed by only 2 surgeons, and both the surgeons, they are performing the same technique. So so we are just having the one standard technique.
Any other questions? So I have one question, in fact, 2. You did say that this was a 5-year survival, but actually your study period was between 2017 to 2021.
Sir.
So how come you came up with 5-year survival?
Yes, I mentioned this was a limitation of our study, that we only included the mortality of patients who were operated in 2017 and 18, because then they were followed for another 5 years.
Okay.
The rest they cannot be followed.
And did they have local recurrence or distal?
Yes, yes, they had previously.
Just local recurrence?
Yes, local.
Did they die of local recurrence?
Initially, it was local. Then they were given the palliative chemotherapy, and then the chemotherapy-related complications started, and then they died.
Okay. So the second question is MSI testing. So we now know that MSI testing is standard of care in stage 2 colon cancer. If the MSI is high and the patients have high-risk features, would you think MSI takes the priority, or MSI high takes the priority and no chemo, or you would look at high?
MSI high, which should take the priority.
Okay. So why do you think those patients with a high MSI and high-risk features were still given chemotherapy?
Oh, like actually, if MSI was high, like obviously adjuvant chemotherapy should not be given to such patients. But maybe because of the risk, or because of the fear, or because of the other risk factors, the high risk factor, then they were given the.
So in your MDT, what would you be recommending if you are the surgeon with such patients, if they present with obstruction, for example?
Okay.
And they have high MSI.
If high MSI and if the lymph node is more than 12, I won't go for chemo.
Okay. Thank you.
Thank you.
Okay. So our next presenter is, if they are around, Dr. Imran Tahir. So he's going to talk to us about incidence of recurrent laryngeal nerve palsy, injury following esophagectomy in esophageal cancer patients. Dr. Imran Tahir.
Assalamu alaikum. I'm Dr. Mohammad Jawad Zahid. I'll be presenting on behalf of Dr. Imran Tahir. I am a second-year general surgery resident at Hyderabad Medical Complex in Peshawar. My topic is that I'll be discussing about the findings of incidence of recurrent laryngeal nerve injury following esophagectomy in esophageal cancer patients. My talk will consist of introduction, rationale, methodology, results, limitations, and conclusion of the study. Just to give a little background, esophageal cancers are they're highly invasive and deadly form of cancer with a 5-year survival rate of 15-25%. And that makes it the 6th deadliest cause of cancer worldwide, and also the 8th most common cause of cancer as well. The esophageal cancer has squamous and adenocarcinoma types, and the squamous type is more known for its involvement of the adjacent lymph nodes, involving the recurrent laryngeal nerve lymph nodes as well. The standard care of treatment that includes is surgery, chemotherapy, and radiation therapy. And they're used in combination depending on the stage of the disease. And also the modern therapies such as targeted immunotherapy is also being used currently. Just to give a little background on a little recap from the anatomy session, we have the recurrent laryngeal nerve runs in the tracheoesophageal grooves on both sides of the neck. It turns around the right subclavian artery on the right side, and on the left side it turns around the aortic arch, and it runs up into the tracheoesophageal grooves. And left-sided recurrent laryngeal nerve actually goes into the thoracic cavity and is more prone to damage in surgery as well. The function of the recurrent laryngeal nerve is to actually help the muscles in the larynx and help in the phonation and breathing of the person. In the previous literature, the occurrence of the recurrent laryngeal nerve injury that has been published is somewhere around 2 to 59%. And the difference in the outcomes is stated to be the involvement of the lymph nodes and the dissection that is carried out. Also, the size and stage of the tumor, and the methods that are used postoperatively to diagnose the recurrent laryngeal nerve injury also has different outcomes based on what different studies have published in the literature. The causes of recurrent laryngeal nerve injury are mainly due to intraoperatively, they can be caused because of either direct damage or use of thermal devices around the nerve, or it can be caused by stretching or compression of the nerves as well. And postoperatively, a hematoma can also cause compression of the nerve that can lead to injury of recurrent laryngeal nerve. The rationale of doing this study at our department was to set a baseline for what was actually going on in our department in terms of patients undergoing esophagectomy and ending up with a recurrent laryngeal nerve injury. And setting a baseline would further help us prevent the problem in the future as well, because then we'll have certain guidelines, certain indications to do certain things in a certain way. Our study included a prospective data. It was manually collected data. We don't have a fancy system in our government hospitals, so we collected through hand-filled performers. It was collected from January 1st, 2022 to January 30th, 2023. And we had 62 patients, and we had them through non-probability consecutive sampling. The study mainly focused on the esophageal cancer patients, and they were staged preoperatively through contrast-enhanced CT scan. And also they underwent preoperative laryngoscopy to detect any dysfunction abnormality in the vocal cords or in the larynx. And we also excluded the patients who had benign lesions, preoperative hoarseness of voice, and advanced local regional disease as well. So these patients were excluded from the cohort. The esophagectomy techniques that were performed were 3. It was thoracophrenolopectomy, it was Machione esophagectomy, and it was yeah, that's that. Anyways, so the data analysis was done through the R programming. And the descriptive variables were in the descriptive variables were for categorical and continuous and categorical variables would have chi-square test and the Fisher exact test, and they were analyzed accordingly. The surgical technique that was used was that we did esophagectomy, Machione, thoracoprenal, and transhiatal esophagectomy. The incision was made in the neck area and anterior margin of sternocleidomastoid. Omohyoid muscle was cut and the staph muscles were retracted. And we tried to avoid the thermal injuries by avoiding the use of thermal devices in the surgical bed in the field, where we thought that we can injure the recurrent laryngeal nerve. Middle thyroid vein and inferior thyroid artery were identified and ligated, and sharp dissection was performed to carefully separate the esophagus from the tracheoesophageal groove. We also used the retractors very carefully to prevent direct traction on the recurrent laryngeal nerve. And once the esophagus was exposed, the affected area was excised and anastomosis was made in the cervical region. This is an intraoperative picture of a recurrent laryngeal nerve, right-sided recurrent laryngeal nerve. Well, our results, as I said, had 62 patients. The mean age was 34.97 years with the standard deviation of 9.96 years. We had 56.45% males and 43.55% females. The age groups were also recorded, in which we had the most participants in the age group of 26 to 40 with 27 participants, and 41 to 58 had 20 participants in them. And the recorded recurrent laryngeal nerve injury that we experienced was around 9.68%. That actually corroborates with the published literature that we have from around the world as well. So as I said, the three most commonly performed procedures were thoracofural laparotomy, McKeown, and transhiatal, and thoracofural laparotomy was most commonly performed. We did a comparison between gender, age group, and surgery type with the recurrent laryngeal nerve injury. And the only significant relationship was found between age group and the recurrent laryngeal nerve injury, and it was most commonly found in the older age group. I would like to say here that having a low p-value does not necessarily mean that it has a cause-effect relationship. It can just say that there was a significant relationship, it did not occur due to any chance. Limitations for our study was that we had a relatively small sample size, but our study was enough powered. And also, since it was small sample size, single center study, so it can't be generalized. It can't be generalized to normal common population mostly. And also the fact that we did not consider amount of lymph node dissection during surgery and the size and state of tumor and their effect on the recurrent laryngeal nerve injury. So we cannot, that sort of limits our result findings. And to conclude, I would say that having a 9.6% of recurrent laryngeal nerve injury is not a small percentage, and it's a significant problem that we face with the esophagectomy patients. And setting a baseline would hopefully help us prevent and come up with the further research and come up with techniques to prevent such injuries in the future. Thank you. I'll be taking questions now. Yes.
How many of them were injected? How many of them were finite?
We didn't check that in our data, so we didn't see it. Yeah.
Cut the strap muscle, and due to sharp dissection between the carotid and over the vertebrae to deliver the esophagus. So the approach is on the left side. So all the recurrent laryngeal nerve injury occur mostly on the left side. Yes, almost all the cases are inappropriately traumatized. After the surgery, we ask the anesthetist to look for the recurrent laryngeal nerve injury after extubation. And also post-operatively, the patient present with the hoarseness of voice. So we check the indirect laryngoscopy is there injury or not. But it is the procedure. Transhiatal esophagectomy has high risk of recurrent laryngeal injury because of blunt dissection, as compared with thoracoperoneal laparotomy or McKeown esophagectomy.
Okay, thank you. Yeah, please.
About the injuries, were they neuropraxias or were they really actual injuries?
Most of them are neuropraxia, and with the time, after 3 to 6 months, they recover. Most of the time they recover, but complete injuries, they're very rare.
Dissection in the neck. No.
Right. I think it's quite important that the presenter should take the questions rather than someone from the audience. Thank you.
First of all, thanks to you that you conduct a very brilliant study. But my question is very simple. First question is that how you calculate sample size, because you took 62 participants. So how did you calculate sample size? Second question is that you performed a chi-square test, which is a non-parametric test. So did you check the normality? Because first we have to check the normality. If it is normally distributed, then we have to apply the parametric, and if not, so then we should have to go for the non-parametric.
So we collected data through the WHO formula. We knew that the previous incidence of the injury was somewhere around 8.6%. So we put that in the formula and we got the number of 62 to enough to know that our study was powered enough to give us results that we can further rely on. And to answer the second question, we did check the normality. Data was normally distributed, and that's why we went for the chi-square. Had it not been normally distributed, we'd have gone for the Fisher exact testing. It's called monograph KS test. Yes. Yeah. It's 30, more than 30, then you do that.
Okay, thank you. So have we got Dr. Muhammad Ansab Shah? Okay, thank you. Yeah, but then we've got the answer. So he's going to present about evaluating the outcomes of completion thyroidectomy in patients with thyroid cancers. Dr. Muhammad Ansab Shah from SKMC Lahore. Thank you.
Okay, Assalamu alaikum, everyone. I'll be presenting evaluation of outcomes of completion thyroidectomy in patients with thyroid cancers. First of all, I have to just say that I have no conflict of interest in this study. A little bit about the incidence of the thyroid cancers is that studies have shown that it's the most common endocrine malignancy and also the fastest growing cancer worldwide. And recently, it's also increasing in its incidence because of the increase in the diagnostic modalities. Subclinical nodules are now being picked up earlier on, and results like that, and are now actually increasing the number of turnover of the thyroid cancers. Another recent update showed that it's more common in the female gender as compared to the males. The ratio is actually 5 to 1 in the study that is shown. It's also the third fastest rising cancer in the United States, and also the sixth most common cancer among the females in Pakistan. Now, it's in a hypothetical situation. If we consider, people sitting in this room and we get ultrasound of the necks of all the people here, then around many will turn out we have subclinical nodules, and only 5% of them will be theoretically malignant. And the real challenge is there is to, diagnose accurately and treat appropriately those patients who have a malignancy in their thyroid. For this, now we have the American Thyroid Association guidelines. There are many other guidelines also available, but the most commonly followed guidelines are the American Thyroid Association guidelines, which are updated recently. The recommendation, according to this, the recommendation that followed in this criteria is that the most important part is that first we have done the lobectomy of the patient. Now we have the histopathology of the patient. If that histopathology, if you consider that if you had that histopathology before the initial lobectomy, what would have been your decision to go either for completion thyroidectomy or for total thyroidectomy or a lobectomy? So if you think that based on that histopathology, you would have gone for completion for a total thyroidectomy, then it's preferable to do the completion thyroidectomy. But if you think that if you had this diagnosis prior to the initial initial surgery, then you would have done the lobectomy either way, and then you would have kept the patient on surveillance, and that should be a better option. So the recommendation also states that thyroid lobectomy alone may be sufficient for low risk papillary and follicular adenomas. Now, the most important part is that the debate is that it's an international debate, and it's mostly about what should be defined as high risk or low risk criteria. Okay, so that therapy that is provided to the patient is mostly based upon the risks and benefits of the therapy. So the debate is that should lobectomy be performed, or either a completion or total thyroidectomy should be done. So what's this? Okay, so we are not the only ones thinking about this. The world is doing further researches to actually gather the weight of the importance of the completion thyroidectomy in patients. So the objective of the study was to analyze the incidence of malignancy in the contralateral thyroid lobe following the completion thyroidectomy among patients who initially underwent thyroid lobectomy. So the estimate is that the completion thyroidectomy is, itself a morbid procedure. It has its complications like hypoparathyroidism postoperatively and recurrent laryngeal nerve injury, and the serial-related complications and postoperative hypocalcemia is also seen. Postoperative hypothyroidism is also seen in these patients. The study was a retrospective single group cohort study done over the duration of 10 years with non-random consecutive sampling technique. And the study was conducted in Shaukat Khanum Memorial Cancer Hospital and Research Center, Lahore. And the data was collected by electronic health records. The inclusion criteria was all the patients who underwent completion thyroidectomy after having lobectomy for papillary thyroid carcinoma, and the patients who were lost to follow-up or had missing data or had some other surgery combined either with the lobectomy or also had a part of the entire operation centered towards the thyroid gland. They were all excluded from the study. So the initial number of patients who had completion thyroid lobectomy for the papillary thyroid carcinoma were 257. After including 40 patients, the remaining study was conducted on 217 patients. The data was analyzed using SPSS version 20, and the quantitative and the qualitative variables were calculated as mean and frequency percentages respectively. So moving on towards the results is that the patients we had were mostly females, as I mentioned earlier. 75.6% of them were actually females, and this is the most important result that we will be discussing, is that out of all the patients who underwent completion thyroidectomy for lobectomy, the contralateral lobe was mostly negative for the malignancy. It was only the 35.9% patients had thyroid carcinoma in the contralateral lobe, as compared to 64.1% who did not have the thyroid carcinoma in the contralateral lobe. That means that most 139 patients had their thyroids and normal thyroid lobe removed. And this is also one of the post-op complications, is that 18.4% of the patients who underwent completion thyroidectomy actually had post-op hypocalcemia. But this is also most important result, is that most of the patients that we encountered had histopathologies, initial surgeries done from outside hospital, and histopathologies were not up to the standard that we produce in our institutions. The histopathology had some missing factors like negative margins and margin status and the disease nodule size initially. So the patients who had the complete data were around 78 histopathologically complete data. Sorry. So the patients who had the histopathologically complete data had 79.5% negative completion rates. So, and only 20% of the patients had the positive malignancy at the contralateral lobe, and the disease. And in these patients, the previous disease nodule that was observed in the initial thyroid lobe, and also the resection margin status, they were statistically not significant. Now, moving on towards the discussion, is that we're not the only ones thinking about this. That's the most important point. The world is, guidelines are there to be challenged after every few years. New data, variety of genetics and the worldwide population is also a contributing factor that may not produce the results that are, available online. So thyroid lobectomy may be sufficient for low risk papillary carcinomas. So, and complete thyroidectomy is its own added risks. So 64% of our population had completion thyroidectomy, which did not have the disease in the residual lobe. This is also comparable to the other studies in the world. The study was published in Korea and Canada and USA. They all have results that more than half of the patients that underwent completion thyroidectomy had a negative, had the contralateral lobe negative for malignancy. This is also another study that this is also another systemic review that I found that states at conclusion that the completion thyroidectomy should be performed judiciously and based on the gross findings and the prognostic factors. And conservative management and follow-up is also a reasonable management strategy for patients with low risk papillary thyroid carcinoma in the initial lobectomy lobe. And as I mentioned earlier, that the completion thyroidectomy has its own significant morbidity, and oncological benefits should also be weighed against the risks of the surgery before presenting the surgery to the patients. And in the patients, also shows the post-operative hypocalcemia is also seen in a lot of patients. So factors like age, tumor size, and the state of the nerve and the pathological features and ultrasound field characteristics of the contralateral lobe should be considered pre-operatively before offering the completion thyroidectomy to the patient. Moving on towards the sense of the study, that it has good sample size and it also addresses the major controversy regarding the management of the papillary thyroid carcinoma. Our limitations were that we had some missing data of the patients, like I discussed earlier, that histopathological data was mostly missing because of multi-centered reports, and our data is also from only a single center, so that's all the ones of the limitations. Moving on towards the conclusions that completion thyroidectomy should be performed only in high-risk patients. Maybe long-term surveillance can be helpful in patients that have low-risk features. And the patients diagnosed with papillary thyroid carcinoma in the single lobe should undergo extensive histopathological, radiological, and clinical workup before proceeding towards the completion thyroidectomy. So I have some important acknowledgements. These are my colleagues who helped me in this study, and I'll be taking questions now. Thank you. Yes, sir. In the patients, we have complete histological data.
I mean, anybody has got any tool to know pre-operatively how to separate that 30 and 70?
So actually, there are nationally published guidelines that what I said earlier is that the major debate is about what should be considered as a high risk feature and what should be considered as a low risk feature. So there are published guidelines, but we have been using those guidelines in our institute as well. They are followed worldwide, but still the results are here. So actually, this was here to open up more horizons to identify more high risk factors, which can actually lead to better rates of less negative completions. So
what were those high risks in your study?
in my study, the initial like I mentioned, that the initial lobe size and the disease margin, they were actually statistically not significant. So the patients who actually we have considered multiple histopathological factors. So the most important factors were poor, like high-grade carcinomas, and also the high-grade carcinomas and the histopathologically advanced diseases. They were the most prone to get the disease in the contralateral lobe, but no definite significance was ruled out.
Thank you.
You didn't mention that what specific test you applied on the SPSS in your, and also it shows that your p-value is high, so your results were also non-significant. Can you please tell us what test did you apply?
Okay, so I'm not a statistician myself, so I actually got help from my colleagues. But it was the chi-square test probably that was applied.
So, what you have said, are you now taking back to the center just unilateral thyroidectomy for patients with low risk, or you're still continuing with the same practice of completion thyroidectomy?
Okay, the current practice actually shows these results. So they actually, to change a practice, you have to identify the high risk factors. Our study was not actually centered towards identifying those high risk factors. It was actually more to what we are doing is it that fine, or should we have to do something to identify those risk factors. So probably a little more work has to be done for initially investigating those patients to get better results.
So how would you plan more work around that? Because it's slightly worrying that 2/3 of the patients with completion thyroidectomy had no disease in the contralateral thyroid lobe, and they had to go through all the surgical morbidities.
So better extensive radiological or histopathological study investigations have to be carried out, and mostly you can keep the patient on follow-up, and if there is something concerning, you can consider them for surgery later on.
So,
you said that majority of your patients were operated from outside hospital. So was that the reason that you could not identify those high risk features? That's why you went for the complete thyroidectomies, or there was another reason for that?
Probably because most of the patients that present in our centers, they usually have a nodule that they had in their life and that was operated outside hospital, and that turned out to be a carcinoma, and the patient was referred to us. So the histopathology reports usually that we get is that there's not enough comment on the margin status or the differentiation grade or whatever. So that's why there was not enough data to actually identify the high risk factors.
Thank you.
Thank you. Thank you. So our final speaker is Dr. Yasir Anam, and he's going to present his paper on clinical outcomes of young rectal cancer patients in Pakistan from SKMC Lahore. He's presenting on behalf of Dr. Amna Munawwar.
Good afternoon, everyone. I'm Dr. Yasir Anam from the Department of Clinical and Radiation Oncology, Shaukat Khanum, Peshawar. I'm going to present the outcome of a young rectal cancer patient in Pakistan, an institution-based study on the behalf of Dr. Amna Munawwar. So colorectal cancer is currently the fourth most common cancer and third leading cause of cancer-related death among men and women globally, with approximately 1.1 million new cases diagnosed each year globally. In Pakistan, the prevalence of colorectal cancer ranges from approximately 4 to 6%. While analyzing this SEER data, there is a 3.3% annual decline in incidence rate of colorectal cancer among old age patients, which were greater than 65 years. And there is a 2.2% annual increase in the incidence rate of colorectal cancer for patients under 50 years during the same period, with the greatest increase in colorectal cancer incidence among the age group between 20 to 34 years. So this is a retrospective analysis of 257 patients from January 2010 to December 2022 at Shaukat Khanum Memorial Cancer Hospital in the Research Center, Lahore. The median age was 36 years, and 68% of the patients were male, while 32% of the patients were female. 76% of the patients were clinically staged as T3, while 22% of the patients were staged as T4. 89% of the patients were clinically node positive, and 11% of the patients were clinically node negative. The most common histological type was adenocarcinoma, which is 74%, and 26% of the patients were mucinous and segmental cell adenocarcinoma. 39% of the patients were poorly differentiated grade 3, 46% were grade 2, moderately differentiated, while 15% of the patients were grade 1, well differentiated. Majority of the patients, 60%, were lower rectal cancer, and the distance from the anal verge were less than 5 centimeters, while 40% of the patients were middle and upper rectal cancer, and the distance from the anal verge was more than 5 centimeters. So as far as treatment is concerned, so majority of the patient, 91%, received long course chemoradiotherapy, while 8 patients, 3.3% received short course of radiotherapy, and some of the patient, 5.7%, received other form of treatment. 70% of the total patient underwent surgery, while 30% didn't have surgery. Now coming to the results, so 59% of the patient didn't have any relapse, local or distant, and they were fine, while 32% of the patient were had distance relapse, while 9% of the patient had local relapse. So the disease-free survival was 59%, and the 5-year overall survival was 70% in our study. So coming to the conclusion, despite all the treatment available, prognosis of rectal cancer in young patients remain poor, with progression-free survival of just 59%. 41.4% of the patient relapse, although they were treated with radical intent. So this study strongly suggests that the survival in young patient of rectal patient is poor, and it needs further study to assess factors responsible for early relapse and poor response to the treatment. Thank you so much.
Thanks, Dr. Yasir. Any questions from the audience, please? Okay. So I have a question. Why do you think the young patients have poor prognosis as compared to?
So, sir, a majority of the young patients had diagnosed with signet ring cell and mucinous adenocarcinoma. And we know that signet ring cell and mucinous adenocarcinoma respond poorly to the new adjuvant treatment. So probably that's the reason that they that early relapse and disease progression.
Any biological factors?
Yeah, so majority of the young patient had MSI low or stable. So this could be one of the prognostic factor also, that they don't respond really well to the treatment.
And how do we know that they have MSI low?
So by testing MSI, testing MMR proteins and MSI.
Okay. Thanks very much.
Thank you so much.
So thanks very much. That was the end of the session. But just before we go, we have got a couple of minutes. Just we have had a very interesting and educational session, and a range of articles were presented. Regarding systemic therapy and role of adjuvant chemotherapy and different surgery papers related to surgical techniques. There were a lot of good things, but I'll focus mainly on things which could have been done better, mainly for the young presenters. So essentially, whenever you're presenting your paper, just make sure that you introduce your topic really well. You come in with a lot of energy and you introduce your topic very well. Because the audience don't know about them, most of them may not even be relevant to your field that you're working in. So you have to present your topic well. Then you have to introduce your content, what you're going to talk about, how and in which order. You should have very good eye contact, not only with the reviewers, but also with the wider audience, because you need to keep them engaged. And just keep it simple. Instead of talking about complex techniques and taking ages to actually get to the actual objective, make sure that you keep it simple and you run through it smoothly. And also keep it succinct. The results should be clearly elaborated. The most important part of your study is the results and the conclusions, because that's where the main focus is. So you need to kind of emphasize on them. So again, there needs to be some oomph behind it. And also at the end, just explain if you intend to change your practice based on this paper. So if you intend to change your practice, how would you do that? Would you then conduct a bigger study, or do you take that as enough proof to change your practice? And if you don't intend to change your practice, then why you don't intend to change your practice? And also kind of talk about similar studies that have been conducted around that area, which either support your study or they refute your results. So that will be quite important. And that way you would be able to convince the audience whether they should conduct similar studies in their centers or whether they should look for other ideas. Thanks very much. Thank you.